This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to the Neurology podcast. My name's Jon Stone. I'm a neurologist in Edinburgh and I've been doing research and clinical work in FND for the last 25 years. And I'm really excited that we are bringing a whole series for you on FND. It's our FND Roundtable. I've got three international colleagues with me, all very experienced in the field. So I'm going to let them introduce themselves.
My name is Sarah Lidstone. I'm a movement disorders neurologist practicing in Toronto and also the director of a rehabilitation program called the Integrated Movement Disorders Program that treats FND patients.
Hi, I'm David Perez. I'm an associate professor of neurology and psychiatry at the Massachusetts General Hospital, Harvard Medical School.
Hello, everyone. I'm Selma Aybek. I'm full professor of neurology in Fribourg University, Switzerland, and I'm leading a clinical program and a research program centered on FND.
Welcome to this third FND Roundtable. This episode, I'm really pleased that we're going to be talking about communicating, sharing a diagnosis, and treatment. This is the thing that many neurologists feel most uncertain about. Sarah, you're running a multidisciplinary service for people with functional movement disorder. Do you want to give us just a very brief overview of how you think about treatment for FND?
Yeah, absolutely. I think the first message for our listeners out there is that FND is absolutely treatable. And what's really, I think, the most important thing is that the treatment is not one size fits all. So it's not like the rest of neurology where we're so accustomed to you make this diagnosis and then the patient automatically, quote unquote, receives treatment X, Y, or Z. It's a little bit different when it comes to FND. There is a big emphasis placed on education and a big emphasis placed on moving towards self-management and being able to engage in treatment, whether that looks like physiotherapy or different types of psychological therapies. And so this is how the treatment for FND differs from the traditional medical model that we're very accustomed to using as neurologists. And so at the most basic step, the first step of treatment, in my view, is a good diagnosis and education. So resources that explain what FND is, that are reliable. Neurosymptoms.org is a great resource for that, and there's many others that are popping up all of the time. And then subsequent to that, really depending on what the patient's top concerns are, right? We already discussed in our first and second podcast in the series that FND can often be a syndrome with many different symptoms. And so what I find is a very helpful step is to really ask the patient, what is it that you struggle with the most? What are your top 3 symptoms, for example? And what are the things that are really getting in the way of you living the life that you want to be living in terms of your symptoms? And then aligning subsequent treatment with whatever those are. Okay, so just because me as the physician might think that the tremor is the most important symptom to treat, if it's not aligning with what the patient actually experiences in their life, that's probably not going to be very helpful and it's probably not going to be very effective. And so options for treatment are physiotherapy. There's now a really good evidence base around the use of motor retraining physiotherapy in functional motor disorders. Psychological therapies, there's a list of those that includes things like cognitive behavioral therapy and other types of psychotherapies that are longer term. And then also multidisciplinary team-based therapies, either as inpatients or outpatients. And so there's a whole host of options that are available now for patients, although in general, these are fewer and far between and under-resourced. So many neurologists talk about how patients with FND can be challenging to treat, challenging to diagnose. And there has to be some type of emphasis placed on improving both patients' experience, but also the neurologist experience. And Jon, do you have any thoughts about how that dynamic can be tackled and improved in any way?
It's such an interesting area because when I think back to talks I would have given 15 years ago, I was probably telling people, try this, try that, that'll make it easier. And increasingly, I think I've got one major piece of advice for people trying to share a diagnosis with patients with FND is just don't be weird. What often happens is the neurologist behaves weirdly. Instead of saying to the patient what they have wrong with them and why they've made the diagnosis, what kind of treatment might help, they say things like, oh, your scan is normal. Or they might start jumping to a discussion about stress or some potential etiological factor before they've even told the patient what they have. So I think my top bit of advice here is just do what you normally do for every other condition. How do you tell someone they've got migraine or Parkinson's disease? You have to start with, you've got migraine, you've got Parkinson's disease. Why do I think you've got Parkinson's disease? Because you've got a resting tremor and bradykinesia. Why do I think you've got FND? Because you've got typical features with a positive Hoover sign or an attack where you fall down, lie still for 3 minutes with your eyes closed, and as we talked about in episode 1. So I've come to the conclusion I don't need to give any specific advice about giving a diagnosis of FND. You should label it the way you're comfortable with, but please just do what you normally do and don't do something weird, would be my top recommendation.
Can I be provocative and ask you, Jon, where you think that discomfort and weirdness comes from?
I think it's a feeling of that many doctors have that FND is something other. You know, we have words like non-organic and organic, where we've lumped together all of the organic things. And then for some strange reason, we believe that there is a non-organic part of the human body which could give rise to symptoms, which if you think about it, doesn't make any sense. It's been othered. I think instead, if we just think of it like a category of human illness, like vascular conditions, inflammation, cancer, it's just a lot easier. So I think people haven't necessarily been made to feel that it's just a normal category that they can treat in any other way. And so they approach the consultation in an awkward way, and then the patient picks up on that, and it often goes badly.
I might also really highlight the importance of our educational backgrounds and trajectories. One of the things that I'm really struck by is that George Engel, a medical internist, published in Science in the late 1970s, the notion of a biopsychosocial formulation, really highlighting that a treatment approach that had a singular focus on biomedicine and pathophysiology in a number of clinical contexts would fall flat or fail to deliver precision medicine. This notion of patient-centered care. And we talked about this in an earlier session, but one of the challenges with FND treatment, as was highlighted, is that what we use for diagnosis, when used in isolation, sometimes doesn't translate very well to a patient-centered treatment plan. And that's where I also think that this field of FND is such a great field for both the general neurologist as well as subspecialty physicians such as movement disorder physicians or epileptologists, as well as a number of physicians across the aisle and clinicians in general that really are interested in this intersection of brain and mind and body. Neurology meets psychiatry meets physical rehabilitation. I think it's just so critically important. And frankly, it's this bit of uncharted territory, in my opinion, that makes this work so impactful and exciting. There are many gaps, though, and I think we're talking about some of those gaps together.
I think we can argue FND is a subspecialty of neurology, and one where it should really attract neurologists who love clinical neurology, taking a history, doing a physical examination, and then using communication skills to really try and help patients. And when it goes well, it can go spectacularly well. I was going to bring you in, Selma, here, just to tell us a bit more about what comes after that when you're giving someone a diagnosis of FND and where you take that.
That is so true that some neurologists feel that these patients are difficult or it's a difficult consultation. I think one of the factors could be that they feel some helplessness. They might be able to make the diagnosis, explain the diagnosis, but what then? Some of the neurologists don't have access to specialized clinic like we have in this panel or like the multidisciplinary center that Sarah is leading. But there are still many things that neurologists can do, and our listeners should be empowered to also reach out to specialists around them. For example, when I have a patient that cannot come to our specialized clinic, I will try to diffuse the information. There are, for example, now a consensus recommendation for physio. So I would make a photocopy of these and give them to the patient so that they can bring that to their physio. And I would make my team available for a phone call to exchange on how is the treatment. So there are other ways also to diffuse the therapy. Same thing with speech therapy, with occupational therapy. So we can do it, of course, in a university clinic or in a specialized center, but there are also a lot of materials that can be used by other specialists. And I think this is very important as a message that neurologists are not alone. They can work in team, even if they don't have access to an FND clinic.
Jon, can you just tell our listeners a little bit more about the consensus recommendations for physical therapy, occupational therapy, and speech and language, all published in the JNNP.
All of those had lead authors that were relevant therapists. It was very interesting with the physio ones. That was the first one because we got together in a room, a group of neurophysiotherapists who'd been treating these patients. And we said, what are you doing that works? And even though they didn't really know each other that well, they were all doing quite similar things. Intuitively, they'd realized that what they were trying to do was promote these automatic movements in FND that were usually quite well preserved and try and retrain the brain, help unlearn unhelpful patterned voluntary movements that form the basis for the FND. And we've seen something similar for our occupational therapy and speech and language therapy recommendations. I say they are recommendations, not guidelines, but they've certainly helped the field move on. And I agree with Selma that quite often it is helpful just to share those with therapists who perhaps don't know about FND, explain some of the principles, become familiar yourself with a few of the ideas in there, just to communicate that this is not necessarily rocket science. It's just a slightly different way of doing what they normally do.
It's very useful, and there's a lot of bedside therapeutic techniques that, as Selma was saying, you can actually do with a patient in their office. So, perfect example where Jon was just talking about this automatic movements are preserved, and that is also a positive sign. So, if the patient, for example, is able to take off their shoes and off their socks, for example, to examine them, and those movements are normal, and then during the examination they develop a tremor in both of their hands and they're not able to hold anything, you point out to them the positive sign that there's internal inconsistency. So they're able to, on the one hand, on the automatic movement of tying their shoes and taking them on and off, the hands worked fine. And then when I go to examine you, now that your brain's paying attention to the exam, the tremor is going to be coming out. And so really the homework, or the exercise, if you will, is for the next 2 weeks when you're at home, try to notice all of the times that your movement is temporarily normal, even if it's just for a few moments or a few seconds. Even that exercise biases the brain to now, instead of looking for dysfunction, to look for good mobility patterns. And a shift begins to happen where the person is now able to notice that their movement actually can be quite good from time to time. And that's actually the beginning of rehabilitation. And that's not through a physiotherapist or a psychological therapist of any kind. That's just from the neurologist giving the patient a suggestion at the bedside.
Yeah, I agree, Sarah. And I think sometimes if someone comes into your clinic thinking they've got MS and they go out thinking they've got some kind of software problem of their brain they've never heard of, but they sound reasonably hopeful about, that's a massive change in cognition. It's not cognitive therapy, but it is a huge shift in cognition that is essential for that rehabilitation. Perhaps most of our listeners are working in a situation where they don't feel that they necessarily have someone to refer a patient to with this diagnosis. What would you say to a neurologist diagnosing functional seizures who doesn't have a specialized sort of FND psychotherapist to send them to? Is there anything the neurologist can do in the short time they have that's going to be helpful?
The first 2 points might be the emphasis on education, on validating the patient's experience. And hopefully there's some comfort on the neurologist side to explore some of the social and mental health components to get a sense, is this part of the active clinical picture or not? Ultimately, we need to team build, and team building is not an easy thing. It doesn't happen very quickly. What I will say on the psychotherapy side, for functional seizures, also known as dissociative seizures, we have a fair bit of robust evidence for cognitive behavioral therapy. We need to think as neurologists, well, what is cognitive behavioral therapy? How is it going to help this patient recover from their functional seizures? In cognitive behavioral therapy, we're exploring relationships between the patient's functional neurologic symptoms, including but not limited to their functional seizures, thoughts, behaviors, emotions, and life factors. Now, with functional seizures, there's a couple of really key components to the psychotherapy approach. And that includes training the patient in relaxation and distraction techniques, exploring with them, might there be warning signs for their events? There's, for example, the phenomena of panic without panic, this notion that there's heart racing and shortness of breath and nausea preceding individuals who go on to then have a functional seizure. As awareness of warning signs and triggers improves, Might there be early patient engagement in use of those relaxation techniques and distraction techniques targeted towards the warning signs to prevent events? And really this notion of patients coming back into the clinic using cognitive behavioral therapy in consultation with a psychotherapist and really reporting back to the neurologist, finding ways to prevent myself from having a seizure. That's really, really powerful. There are a number of workbooks published in the field that can really help catalyze how to build teams and how to have neurologists also educate their psychotherapy and psychiatry colleagues on what's available. It's this crosstalk. One doesn't have to know all the aspects of psychotherapy to engage in that crosstalk, but being an interested neurologist who says, let me chat with my psychotherapy colleagues about this patient population, and let's see if we might be able to build a pathway together. This can be really wonderful.
I think it's about encouraging people that even in 5 or 10 minutes, that the neurologist who's made the diagnosis is in such a good position. If it's gone well, they're in such a good position to help that patient just move a little bit further. Not necessarily giving all the treatment, but just describing roughly what it might consist of, which for some patients, they can really pick up that ball and run with it, I find.
So important, John, including having the neurologist remain involved longitudinally, right? So that maybe they're helping to coordinate to get the patient connected to other services, but then let's schedule follow-up and let's walk this therapeutic journey together. I think that's really, really important. And I think as a neurologist, it's important to walk that therapeutic journey with our patients.
Certainly one of my bugbears, I suppose, is about follow-up, because I think if most of us diagnose someone with multiple sclerosis, we would arrange to see them again. You know, you've told someone they've got multiple sclerosis or Parkinson's. You see the patient again because you want to know how they're feeling, what do they think of the diagnosis. We've got this weird habit in our specialty of not seeing people with FND, which means that you're not really sure how your communication went down. One of the things you'll discover, by the way, is that if you just give people a website for FND and say goodbye, that is not enough. And I say that as someone who made a website for patients. I think information helps, but that follow-up can be a crucial appointment to actually find out, does the patient agree with you? Is it the right time for them to have therapy? In my experience, it isn't always the right time. Sometimes it's best to wait, or sometimes the patient just isn't looking for therapy at that moment. They just want some peace of mind about what's wrong.
I think that's also a really important point as well, is that the patient's not always going to agree with you. And that's okay, right? Your job as a neurologist is to do a really good, thorough evaluation, diagnose FND and any other comorbidities that might be present based on your good, careful history examination and investigations if necessary, and provide a diagnosis as empathetically as possible with good resources and education. And if with all of these boxes being checked, the patient doesn't agree with the diagnosis, wants more opinions, then I think that's okay. The patient doesn't have to agree with you. And it's not your job to have to convince anybody that they have a specific diagnosis. And I think that people need to hear that message and be reassured, because as Jon, I fully agree, not everybody is ready for the diagnosis or even for treatment at the time of assessment. And hopefully down the road that might change in subsequent follow-up.
And for the treatment to be collaborative, I think that's so important, right? As a clinician, we can provide our opinion, but we should also allow flexibility for the patient to disagree with our opinion and to just have a transparent conversation about what might be the best path forward.
And I can jump in on that based on our experience also in an FND clinic, is that we have an inpatient program, for example, but even before considering this inpatient stay, we always make a consultation with the patient to discuss about the aims. It's very important that the patient agrees and knows what is expected, and that we have common goals, that we don't have over high expectancies, and then the patients are disappointed about the treatment because it doesn't go as fast as they can. And that can have also a negative consequence on the team that gives everything that they can, and still the patient doesn't improve. So this is really important, as you mentioned, all of you, to have the right timing for such a treatment. So I guess it's really to have a tailored treatment plan between the treating neurologist that should, if they want and can, stay involved, and the specialized centers.
So I think what we've heard there is the importance of thinking about triaging the patient. Is it the right time for this patient to have treatment in their understanding of their condition? But what I would say is that when you treat FND, it can be a fantastically rewarding experience. When patients have been unable to walk, they can walk again, they're having lots of seizures, the seizures stop. This is as rewarding an area of clinical neurology as any, in my experience. So I do hope that our podcasts have encouraged you to feel hopeful about FND and to give hope to your patients. We made 3 podcasts, one on diagnosis, one on the how and why of FND, and this one was on treatment. It's been such a pleasure to have my 3 guests with me, Sarah Lidstone from Toronto, Selma Aybek from Freiburg in Switzerland, and David Perez from Massachusetts General in Boston. Thank you to all of you, and I hope you've enjoyed the podcasts.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.